everybody, and welcome to our Medical Minute that is sponsored by Kroger Health. A couple weeks ago, you guys had tuned in for episode number 67. Today is episode 69, and we are doing Lung Cancer 102 as a continuation of our one from a couple weeks ago. With me today, I have my colleagues, Andy Guinigundo and Dr. Jazieh. And they are the gurus of lung cancer here at Cincinnati Cancer Advisors. So they are going to really kind of take us into a deeper dive on some of the genetic testing and precision oncology. We're going to talk about some of the treatment options that are out there, advantages, all of the things that you might want to know once you have a lung cancer diagnosis and you're looking into potential treatment options. I cannot promise that we are going to keep this short because there's a lot of content to cover, and I want to make sure that we give you as much detail as we need to really cover the topics so that you all have a very good understanding. So we're going to jump right in where we left off from Lung Cancer 101 and get into some of the genetic testing and precision oncology, which is kind of a buzzword.
Yeah, no, when I see patients here at Cincinnati Cancer Advisors, what I often do is start out by explaining that there's really two kinds of genetic testing, so to speak. So when we talk about hereditary genetic testing, that's what people mostly think about is, oh gosh, did I inherit something from my mom or my dad that has raised my risk for cancer? In terms of lung cancer, they've really not identified a, pardon the pun, quote unquote smoking gun gene for lung cancer. So there's not like a BRCA1 or a BRCA2 that you would see for breast and ovarian and prostate cancer, or with Lynch syndrome with colon cancer. There's not those genes or sets of genes that are associated with lung cancer. Interestingly enough, though, there was a study that they looked at 8,000 lung cancer patients who got testing for other reasons. So people who had not gotten tested simply because they have lung cancer, but because they had other reasons to be tested, meaning that, oh, geez, I have lung cancer, but mom had breast cancer, and all my aunts had breast cancer and ovarian cancer. So they tested them for a wide genetics panel looking for genes. And of those 8,000 patients, close to 15% of them had some sort of mutation. So that's higher than you would even predict. Some of these breast cancer factors. We think of that kind of that 10% range in terms of number of breast cancers that are due to genetics. And so here we're talking about lung cancer patients, and even though they're being checked for other reasons, 15% of them being having some sort of mutation that increases their risk of cancer. We've found patients with BRCA mutations who we've ended up using BRCA-related treatment to treat them with, interestingly enough. So that's the hereditary testing. And definitely we are seeing a way more widespread use of what we call genomic testing or molecular testing. Everything has to have 10 names in medicine, right? Mm-hmm. And so that is actually genetic testing of the tumor specifically. So oftentimes what I tell patients is, what makes that tumor a tumor is its genetic makeup is different than every other cell in your body. And that's what we're looking for. And that's when we talk about, when we get into some of these new fantastic drugs, that's what we're looking for to target in those.
Great. Well, that was a great lead into talking about some of the drug therapies that have evolved over the last several years for our lung cancer patients. And they definitely fall into multiple different categories. Dr. Jazieh, can you speak a little bit to that?
Sure. So actually, drug therapy can be divided into three categories. One is the chemotherapy, which we know and we have been using for decades. And even that, there is some slight improvement in the regular chemotherapy. But actually, that was, not significantly changing the outcome of the patients. The next line of treatment that came, and it's immunotherapy actually, which is actually changed the outcome of the disease, as we mentioned earlier, and it works in a different mechanism where it does not attack the cancer itself, but it enhances the immune system to recognize the tumor and attacking it. And the third type of treatment based on the genomic testing is actually the targeted therapy. And there, as I said earlier, there are almost dozen genes that we have treatment for them. And some of the genes have even 5 drugs available in the market that are effective in treating these patients. So some of these mutations, and it's like alphabet soup, as Andy says, we're not going to go through all of them, like EGFR, like ALK, ROS1, BRAF, and so on. So there are multiple of these genes. And actually the difference between these medications that are usually, they are oral medication, they are taken by mouth, so they are very convenient for the patient. They are more efficacious, they have better responses in the disease shrinking, and the patients have better disease control and survival and cure rate. And, they are also have different side effects because they attack the tumor mainly in a smart way. They have less of an immune suppression, for example, or hair loss or other side effects that are known for the classic chemotherapy. So they really changed the map of and the landscape of treatment of lung cancer significantly. And it's not uncommon, as I said earlier, that you have people who are with stage 4 who were incurable in the past that have disease control or complete remission for 5, 10 years and more. So it is actually now they call lung cancer almost the poster child of precision medicine.
Yeah, absolutely. Now, if a patient has a lung cancer diagnosis and they're looking at, they're going to meet with their medical oncologist and they're going to talk about their treatment options, and they know that we have these buckets of treatments. You have the chemotherapy, the immunotherapy, and the targeted therapy. Now, what can they expect when they meet with their medical oncologist? Is the medical oncologist going to say, well, we're going to try the chemotherapy, and if it doesn't work, we're going to do the immunotherapy, and if it doesn't work, we're going to do the targeted therapy? Or are they going to get everything but the kitchen sink thrown at them where, well, you have a mutation, so we're going to give you everything at one time? What can patients expect when we talk about all of these great options of treatments? What is typical for patients when they're first diagnosed and they have to do some sort of systemic or IV therapy?
Yeah, this is a very important question. And actually the best advocate for the patient is the patient himself. And the more knowledge they have about the disease and what is expected, the likely that will be in participating in the decision making and have a better a treatment decision for them. So first of all, the first thing we've talked last episode that we need to know the type of cancer you have, lung cancer. But the second important thing that you need to know, and you ask your doctor about it, is what is the stage of my disease? Because the treatment is stage dependent. So if it was stage 1, 2, usually surgery should be part of it, and some of the stage 3. Once you are in stage 3, specifically, there will be combination of treatment. So that we may actually throw the kitchen sink, as they said, because you need to do radiation and chemotherapy sometimes, then followed by surgery in certain cases, and followed by immune therapy in some cases, or targeted therapy. Now, so that's generally for stage 3. When you come to stage 4, every patient should start with having next-gen sequencing, doing mapping of profiling and mapping of the tumor to see if they have targets. If they have targets, so some of the targets, not all of them, take priority over everything else. So for example, if they have EGFR, ALK, ROS1, usually there are drugs for them, so they start with that. And that is usually by itself is enough to control the disease and have good response and so on, and there's no need to mixing stuff, with chemo or immune therapy. Now, if they have certain markers that some of these testing also will show us if they have markers that, give us a good sign that they may respond to immune therapy but not to target therapy, then we have to put the immune therapy in the equation. But those who don't have an actionable target, usually they get mixture of chemo and immune therapy to get the best outcome for their treatment. So starting with next-gen sequencing, profiling the tumor, see if you have actionable targets, And based on that, the decision will be branched into getting targeted therapy or chemo and immune therapy.
Perfect. Thank you. So, Andy, you and I tend to deal with a little bit more of the frontline one-on-one with the patients. And a lot of times their biggest concern is, okay, yeah, I have a cancer diagnosis, but is the treatment going to make me miserable? How is it going to impact my life? What kind of quality of life am I going to have? Because if it's going to be horrible, then I just don't want to do anything at all. So with these treatments, with the combination of chemo and immunotherapy versus our oral targeted drugs, what does that look like for the patients on a everyday basis? Are they going to expect to be sick and miserable and not be able to function? Are they going to be able to work? How do these medications impact the patient as a person?
Yeah, I guess it's one of those situations where it depends. Even with our traditional chemotherapies that unfortunately have remained the same over decades. Fortunately, some of our support medications have certainly gotten better. As you and I both know, what we use for nausea today is not what we used for nausea in the 1990s, and so. You probably weren't practicing.
No, I was still in
You were high school then?
Yeah.
But yes, so these things, so support medications evolve for sure. But this whole idea of having a targeted therapy, you have a drug that is targeting something specific on the tumor. Again, speaking in general, it seems to be less collateral damage, so to speak. I always describe chemotherapy as kind of like the shotgun approach. If you had hostages in a bank and you came firing with a shotgun, you get the bad guys, but you might take out some good guys and hostages in the process, and that's not so good. To continue on with the weaponry analogy, maybe not so kosher these days, but targeted therapy is like that sharpshooter on the roof across the street. We can wait for the bad guy to cross the window, then take him out that way. And so when you are able to target something specific on the tumor, you get less of that collateral damage. Again, it's not completely without that would kind of be the holy grail, so to speak, of drugs, is to have the drug that only attacks the cancer and leaves everything else alone. We're not there. We strive for it, but we're just not there. There is certainly some, be it diarrhea or rash or other things that occur with some of these targeted therapies. We certainly see that, but these things can be supported through. We've had patients, for example. That we all know who've, as Dr. Jazieh alluded to, been on immunotherapy. A patient who's been on immunotherapy, when we were studying nivolumab before it even got approved, and still on therapy now. So you were talking about going into the early 2010s. So this is a guy who's been on therapy for over 10 years, and believe me, he's living his life. So these aren't people who are I'm in bed and just flipping watching TV. They're out there living their lives. They're traveling. They are doing things that perhaps 10 or 20 years ago we would have never imagined for someone with stage 4 lung cancer. Yeah.
Great.
So the goal is basically to change the lung cancer from a fatal disease to a chronic disease. So it will become like high blood pressure, diabetes. You take the medication for it once in a while, or a pill a day, and then you live your life.
I was actually thinking that the goal would be to eliminate 85% of lung cancers and everybody just not smoke. We could definitely get up on a soapbox when it comes to that, especially for our younger generation. It's really hard for our older generation who's been smoking for 30, 40 years, because when cigarettes first hit the market, I don't think anybody had an idea of what a negative impact it was going to have. And we definitely don't want to paint a picture that, smoking and stopping smoking is some super easy thing to do. I think that there was actually a a paper that was released that showed that the addictive nature of nicotine and smoking was more addictive than heroin.
Yeah. Well, I tell you, I have a doc I used to work with for a long time who used to say all the time about smoking cessation was that what, worthwhile, meaningful thing in your life did you ever try once and did it perfectly? Right? No one ever jumps on a bike and just starts riding. You fall a few times and skin your knee, and so if you fall off the wagon and start smoking again, get back up and say, okay, let's try this.
Let's regroup.
Maybe we do it a different way. Maybe I did the patch that time, that didn't work so well. Maybe I tried the pills this time. There are different ways to do it, and it just means that you need to try and try again.
All right.
Yeah, keep in mind smoking also kills in many different ways besides lung cancer, so it increases the risk of many other cancers. Actually, if you are looking from satellites down on Earth, every time you count, if you say 1, 2, 3, 4, 5, 6, somebody dies from smoking effect. Every 6 seconds, somebody dies from smoking effect in the world.
That's big.
Profound.
Yes. So, and the nice thing is that for those who have been smoking and do develop lung cancer or develop lung cancer for a reason other than smoking, we're definitely seeing progress in the treatments. So,
well, and you made me think of something also. Even once you're diagnosed with lung cancer, stopping at diagnosis is not too late.
Right.
We know that there have been a multitude of studies that show that even stopping at the time of diagnosis, that people live longer. Obviously, your function is better, heart and lungs and all that stuff is better, but they tend to even live longer, even perhaps from a less disease progression when people stop smoking at diagnosis.
Awesome. All right. Well, that is going to be a wrap for Lung Cancer 102. Hopefully we have dug in and answered lots of questions. Obviously, if you have any additional questions, you can comment, and we would be more than happy to try to get back with you. But as for today, we're going to call that a wrap, and thanks for tuning in.